Hello. We'll start our second lecture in our series on drugs and human behavior by talking about pharmacokinetics. This is an incredibly important topic to understand all drug use, and this is something once you learn you can apply to a variety of different drugs. Every drug you might ever take follows very similar pharmacokinetics to the drugs we'll be talking about. So understanding the basics of this process is an incredibly important skill for you. So when we talk about pharmacokinetics, I want to provide a brief introduction to what we're talking about. It sounds like a big scary topic, but it's really relatively easy to understand once you break it apart. There are several different steps in the process of how a drug enters the body, makes its way around, gets eliminated, etc. So we're going to talk about drug absorption, how drugs get into the body, drug distribution, how they get distributed throughout the body, how drug action gets terminated, how drugs get eliminated, and then we'll talk a little bit about drug tolerance and how that relates to pharmacokinetics. So there are four core processes in pharmacokinetics: absorption, distribution, metabolism, and elimination. So we'll start with absorption. This is just how a drug gets into the body. However it gets in, we'll talk about the variety of ways that happens. Distribution is how the drug gets distributed throughout the body and where. This is really important for psychopharmacology because not every drug or substance can cross what's called the blood-brain barrier, and that's going to be very important as we talk about different drugs and ways in which we might be able to prevent people from using them. Metabolism is how a drug is broken down into waste products. Again, very important to understand. Some of the things you might eat or drink can influence metabolism, and so we'll talk a little bit about that. Finally is elimination, which is how a drug leaves the body, and there's only a few ways that that can happen. So, quick summary here: absorption, movement of drug from the site of administration to the blood; distribution, movement of the drug from the blood to the rest of the body; metabolism is the breakdown of the drug; and elimination is the removal of drug's metabolic waste products from the body. These four processes determine what we call the bioavailability of a drug. So, for example, how much of a drug makes it into the bloodstream is going to depend on its absorption rate. So if a drug is presented transdermally on the skin, some of it will make it through. If it's taken orally, some of it will make it through, but certainly not all of it. And this is an important thing to understand when we talk about things like dosing and trying to understand overdosing. Distribution: how much and in what form does the drug cross the blood-brain barrier? Not all drugs can do that, and some drugs have to be bound, that is, bound to another protein. Sometimes they have to undergo what's called first pass or second pass metabolism, that is, they have to be metabolized first before they cross the blood-brain barrier. It's an important question. How quickly is the drug eliminated? Is there an active metabolite created in the process? So this is metabolism. In a number of cases, an active metabolite will be created in the process. So for example, we'll talk about how cocaine, in the presence of alcohol, creates cocaethylene and creates a whole new different metabolite. We'll talk about painkillers that have to be metabolized first in order to provide their pain-killing properties. So as we start understanding drugs in the body, we have to understand a little bit about how they get in. And so how do drugs get into the body? And so there are a variety of ways this happens through different injections: intramuscular injections, intravenous injections, transmembrane, which a drug is provided on a mucosal membrane; subcutaneous, it's injected underneath the skin; transdermally, it's presented on the skin; inhalation, of course, is smoking or other types of inhalation. So we talk about an oral dose. It goes to the GI tract, can get metabolized, then make its way into reabsorption. An IV dose is going to go straight into the bloodstream, has no other sort of metabolism. Transdermally, intramuscularly, and subcutaneously, it's going to be involved in distributing across tissues. Transmembrane, similarly, has to go through a membrane absorption. And then inhalation, absorbed through lung tissues. Inhalation and intravenous are the fastest routes because they tend to go straight into the blood and from there straight to the brain. So understanding this process is critical for understanding drug dosage and effects. I want to talk about how this whole process works by looking at two different drugs, triazolam versus lorazepam. And selection of a specific drug will actually depend a great deal on the therapy in combination with, the goal of therapy in combination with the drug's metabolism. So if we take a look at triazolam in the orange and lorazepam in the green, if we're interested in providing a long-term relief from anxiety or help with sleeping, for example, so we want to provide a long period of time where the drug is in what we call its therapeutic range, we obviously want something like lorazepam because that's going to last for 10 to 12 hours in the therapeutic range. It's going to take a little while to reach its therapeutic range, but it will stay there for quite a while because it has such a long metabolic half-life. Triazolam is very quick acting and very quick metabolism, so it's going to act a little bit faster than the lorazepam, but it's also going to wear off much faster. So if the goal is simply to get someone through an MRI procedure, for example, they're very anxious about being in an MRI tube, and who isn't? We might use a drug like triazolam because that's going to allow them to have a couple of hours of anxiety relief, but very quickly be over it and back to their old selves. So the goal of a drug treatment is going to really have some relationship, a great deal of relationship to the metabolic properties of the drug chosen. So with that in mind, the next important thing to understand about drug administration is how the routes of administration, how a drug gets absorbed. Now, most of the time, there aren't a lot of choices in terms of which route a drug might be administered. But understanding the differences and how they alter drug metabolism is particularly important. So we'll talk about these various routes of administration. Enteral routes are those that are administered via the GI tract. So these include oral administration, so pills, liquids that are drank, that sort of thing. Rectal administration, so these would be suppositories or other type of rectal administration. People do very strange things like liquor enemas, and so that would be a rectal administration of alcohol. Now, it's an incredibly dangerous thing to do, and we'll talk a bit about that when we get to alcohol, but it's certainly a way in which alcohol can be administered. Parenteral routes are just all the rest of the routes that don't involve the GI tract. The GI tract is different because it does have various enzymes, acid, for example, and so alcohol, for example, the GI tract contains quite a bit of alcohol dehydrogenase, which breaks down alcohol in the GI tract. And so that enteral route does have a lot of distinctions to it. Some drugs simply can't survive the process. You can't administer testosterone, for example, via a pill because it gets completely broken down in the GI tract. So the parenteral routes are those not involving the GI tract. So injections, inhalations, transdermal, absorbed via the skin, intranasal or mucosal, so it's absorbed through mucous membranes. And so these are the primary routes that we're going to talk about. We'll start with oral administration. This is obviously the most common way that people take any drug we might think about. In order for a drug to be administered, it must be soluble and stable in stomach fluid. It has to be absorbed through the upper intestine through passive diffusion. And it must be generally somewhat lipid soluble. That means it's dissolvable in fat. Some drugs are not lipid soluble at all, and some drugs are only lipid soluble. So a drug like Xanax or alprazolam is only lipid soluble. It's not water soluble. So alprazolam is a poor choice for injecting, and it's a terrible choice for something like intranasal administration. People who abuse drugs will sometimes crush Xanax and snort it, which does nothing because Xanax cannot be dissolved in water, and so it doesn't pass through the water-based submucosal membranes. So drugs that are orally administered have to be a little bit more lipid soluble, and the more lipid soluble they are, the more they will be absorbed through the GI tract. This is going to become important when we talk about marijuana. So food for thought, what you eat might matter. That is, with some drugs, if you had a high-fat meal and then you orally administer a drug, you might get a much larger dose of the drug. So for example, marijuana edibles. Marijuana is highly lipid soluble. So if you had a high-fat meal, ate a bunch of deep-fried food followed by ice cream, and then had a marijuana edible, you're going to absorb much more of the marijuana than you might if you had something else to eat. So it's really important to understand how what you eat affects the oral administration of drugs. Some disadvantages of oral administration. Obviously, you can get vomiting and some stomach distress. Drugs like Advil, ibuprofen can have negative effects on the GI tract. It's hard to know how much of a drug will be absorbed due to genetic differences, gender differences, lifestyle differences. We're starting to again understand things like that human biome, what kinds of good bacteria you might have in your GI tract can certainly have an influence over the absorption, distribution, etc. of different drugs. So, and of course, stomach acid is going to destroy completely some drugs depending on its contents. Finally, the rate of absorption will depend on if the drug is in a pill or liquid form. Obviously, pills take time to break down. In fact, many pills are designed to dissolve slowly over time. So many formulations of pain pills are formulated so they will dissolve slowly over time. Of course, people get past that by chewing them or crushing them up and snorting them or doing other sorts of alterations to pills. So chewing a pill, for example, will dramatically change its absorption rate, and so you'll absorb a drug much faster. So you want to be very careful and not do that unless it's a drug that is meant to be chewed, like a chewable vitamin. Rectal administration can be used if the patient is vomiting, unconscious, or unable to swallow. Absorption is often irregular, unpredictable, and incomplete. I think you can probably figure out why it might be incomplete. It might not stay there very long. Also, it's not the same level of acid and whatnot to break down compared to, say, a pill that is swallowed. But you can do rectal administration of a variety of drugs. Administration by inhalation. This is popular, of course, for recreational drugs. Of course, tobacco, which is the way nicotine can be administered. Of course, vaping is a new way to do that as well. Primary way most people consume marijuana is through inhalation. Cocaine, if it's combined with baking powder, baking soda, I think. Sorry, not my area of expertise in terms of how to smoke cocaine. But it can be made so that it can be vaporized and inhaled. Of course, crystal methamphetamine is oftentimes inhaled by vaporizing the crystals. And of course, heroin also can be smoked. The lung tissue's large surface area allows for rapid absorption into blood. The pulmonary capillaries carry the drug directly into the left side of the heart, and then directly into the aorta and arteries and go right to the brain. So very, very rapid onset. Of course, there are drugs that are administered by inhalation that are not illegal narcotics. A variety of inhaled steroids for asthma users. Of course, there are inhaled anesthetics, nitrous oxide. All those sorts of drugs can also be administered by inhalation. It's an efficient way to get drugs into the bloodstream. So it's often an even faster onset than injection for some drugs. Now, the difference is in terms of the dosage administered by inhalation versus intravenous. Intravenous usually oftentimes will involve a larger dose, so it's a really important thing to be careful of. Administration through mucous membranes. Again, these are any mucous membrane in the mouth, nose, eyelids even. There are a variety of examples of this. Heart patients who take nitroglycerin will put that underneath their tongue. It's called submucosal. Cocaine, of course, is often the primary way in which it's administered is intranasally. There are, of course, nasal decongestants. Some antihistamines are administered nasally. Nicotine gum is a submucosal version of that particular drug. So it is an efficient way to get drugs directly into the bloodstream. Transdermally, another interesting route. The skin is the largest organ in the body. Administration can be through a skin patch. So oftentimes this is nicotine replacement therapy. Fentanyl is often administered via skin patch because it will slowly distribute, so the patient gets a slow, steady dose of this very potent painkiller. Some hormones like estrogen and testosterone are administered through skin patches. Birth control pills can be done via the skin, so it is an efficient way to absorb drugs. It's really important to understand your skin does absorb things from the environment, and so thinking about what's in your water, what's in your soap, what's in the pool you get into, all of that stuff can get into your body. So it's really important to think about that when we're doing anything. So if you get pesticides on your skin, you want to wash it off immediately. It's not that it's necessarily going to hurt your skin, it's going to get absorbed into your blood, and then it has some pretty negative effects. We talked in our previous lecture about acetylcholinesterase inhibitors, and pesticides are in that class and can in fact cause pretty significant damage. You can also administer through gels, and in fact testosterone is available in an underarm deodorant gel. So you just or an underarm roll-on, so you roll it on that way. So a variety of ways in which you can get drugs administered via the skin. Of course, administration by injection is a very common practice. Intravenous administration is where a drug is introduced directly into a vein, into the bloodstream. The dosage here, of course, can be extremely precise. That's one of its great advantages. So when we conduct research on pharmacokinetics of drugs or on the effects of drugs, oftentimes intravenous administration is the best route to go, because we know as soon as the drug hits the bloodstream, we know exactly how much is administered, and we know exactly how fast it's going to come on. That is, how quickly it's going to be administered. Unfortunately, this is also the most dangerous route for drugs that are abused, and most people that overdose using drugs intravenously. This is a huge epidemic we're going to talk about when we talk about opioid painkillers. One of the things that can happen is users will get a particularly potent batch and not know it and use their usual dose. They will not use for a while and then use again, and then their body's not used to it. There's some move that we'll talk again about here in the coming weeks about some ideas for providing safe injection sites so that people can be administered drugs to reverse the effects of an overdose if that should happen. So we'll talk about that. It's going to be a really important policy discussion we'll engage in here shortly. Intramuscular administration, drugs are injected into skeletal muscle. Obviously, this is done with antibiotics often. It can also be done with other painkillers. More rapid than absorption from the stomach, but slower than intravenous injections. You can get sort of different types. Type 1 is a rapid onset, short duration of action, where drugs are dissolved into an aqueous solution. Type 2 is a slow onset, sort of prolonged duration type injection, where the drug is suspended in an oily solution, and it takes a longer time for it to be absorbed. And so these two have different kinds of properties to them and for different reasons. Subcutaneous administration, a drug is injected under the skin, and then it's absorbed through the tissues that way. Very few psychoactive drugs are done this way. Usually subcutaneous injections are done for localized anesthesia, that sort of thing. Oftentimes, for example, they will inject a little bit of lidocaine under the skin where they're planning on putting an IV in order to make that less painful. So here's a quick summary of the three different kinds of injection. Intravenous, intramuscular, and subcutaneous are all three different ways in which drugs can be injected. So once a drug arrives into the bloodstream, so it's been absorbed through the GI tract, it's been injected, it's been absorbed through the lungs, it's distributed via circulating blood. So a drug will have an effect once it reaches what we call its site of action, that is, its receptors. So we're going to focus entirely on the brain and the receptors there as the site of action for most of the drugs we're going to talk about. But remember, most of an administered drug will be elsewhere. So if you're interested in trying to target the brain, you're still going to have drugs everywhere else throughout the body. And so that is where we get a lot of side effects. And that's one of the biggest problems with drugs is they end up everywhere. And so you have to be very careful about how a drug is administered, particularly for pregnant women, because almost all drugs will cross the placental barrier and end up affecting the fetus as well. So for a drug to be absorbed, it must pass through the capillary walls. Capillary walls consist of a single layer of cells. These are holes or pores between those cells. Of course, nutrients, waste, and drugs can move in and out of those pores. So red blood cells and large protein molecules are too large to move through these capillaries, but injective drugs move through the capillaries and blood by diffusion. So if you inject a drug, it's going to go out through the bloodstream and then diffuse out through the capillaries. And so this is how drugs end up in the brain. The brain is, of course, one of the most highly vascular surfaces. The eyes are also a highly vascular surface, so any drug you might use can have effects on the eyes. So keep that in mind. I think that's something you always want to watch out for. You only get one set of eyes. So drugs move throughout by diffusing out through those capillaries. Drug molecules can be found in different places in the blood. Plasma is, of course, more likely with water-soluble drugs. Plasma is really more water-based. Platelets are more likely with lipid-soluble drugs. That is, drugs are likely to end up in platelets if they are lipid-soluble. They can also be attached to proteins like albumin. And we talk about these as being bound versus free versions of drugs. So for example, testosterone, you usually have two circulating versions, bound versus free testosterone. Bound testosterone can cross the blood-brain barrier, free testosterone cannot. And so that's an important distinction to understand about how drugs get distributed. One other critical thing to understand about drug distribution is what we call first-pass metabolism. First-pass metabolism. Before the blood goes to the rest of the body from the GI tract, it passes through the liver. So you absorb something through the GI tract, it passes through the liver. The liver is, of course, the major organ that breaks down most drugs because that's how drugs get metabolized. Therefore, a certain amount of the drug can be inactivated or metabolized as it passes through the liver. This first-pass metabolism is an important part of understanding how drugs end up in the bloodstream and also might not end up in the bloodstream. So other routes might not be subject to this first-pass effect because they've been administered somewhere on the other side of the liver. So it's already past the liver in its distribution. So drugs that are administered orally are broken down in this first-pass metabolism by the liver. So here's how this might work. We have blood circulating. Let's say we go into the brain, out of the brain, into the heart, back out of the heart, to the intestines. So we absorb something in the intestines, goes through here to the liver. So it's going to pass other places as well, but it's go through the liver, and then it's going to go back through the heart and back up. So something that's absorbed through the intestine has to go up here, through the liver, and then back through the heart, and then back up to the brain. One of the things that happens in this process is particularly relevant to alcohol. Alcohol is broken down in the GI tract by alcohol dehydrogenase and also in the liver by alcohol dehydrogenase. One of the issues that will come up when we talk about alcohol use and abuse is that women have substantially lower levels of this enzyme. This is the reason why when they talk about the limits for people drinking alcohol for, say, driving, that men's levels of drinking are usually about twice that of women, and that's because women have much lower levels of alcohol dehydrogenase. We'll also talk about how there are some races that have very, very low levels of alcohol dehydrogenase, and as a result get drunk very quickly, and in fact are at much higher risk for alcohol poisoning. So we'll talk more about those when we get to discussing alcohol. I want to make another quick note about first-pass metabolism is a quirky effect of grapefruit. Grapefruit juice and eating grapefruit blocks one of the enzymes that's used to break down certain drugs, and it's the cytochrome P3A4. So grapefruit juice is what we call a cytochrome P3A4 inhibitor. So it will actually increase the absorption of some drugs and decrease its metabolism as a result. And what that ends up in is some drugs end up having a much higher effect or longer effect in people who eat or consume grapefruit juice, or eat grapefruit or consume grapefruit juice, because that enzyme has been blocked. So, for example, Buspirone, which is marketed under the name Buspar, has relatively normal metabolism and metabolizes out very quickly. In the presence of grapefruit juice, however, there is much higher levels of absorption and much longer presence in blood. And so as a result, people who are on Buspar need to not consume grapefruit juice, because it radically increases the amount in their blood and can result in some significant problems. Most of the benzodiazepines also are metabolized by cytochrome P3A4 and are others. And so you just want to simply be careful when consuming any drug in combination with grapefruit. And grapefruit, the effects of grapefruit last. So one of the important things to understand about drug distribution is there are a variety of body membranes that actually affect drug distribution. The first are cell membranes. The second are capillary walls, the blood-brain barrier, and then finally the placental barrier, which we'll find is not much of a barrier at all. So let's start with cell membranes. Cell membranes are made of a phospholipid layer, as we saw when we talked about the cellular membrane of neurons. Membranes are only permeable to small lipid-soluble molecules. These are important as barriers to absorption and distribution of drugs. So not very many drugs can actually make it across the cell membrane. In fact, most psychoactive drugs have their influence by affecting the outside of a neuron by binding with neurotransmitter sites. Capillaries are another barrier or body membrane to drug distribution. These are, of course, the tiny cylindrical blood vessels that have small pores, which are larger than most drugs. These allow transport of drugs regardless of their lipid solubility. But blood and protein are too big for pores, so drugs that are bound to plasma proteins cannot pass through and just remain in the blood. And so that's important to understand as well. So anything that binds to those proteins cannot pass through the capillaries. The blood-brain barrier is particularly important for us to understand. The brain must protect neurons from toxins, and so it must block those out, but the brain has a great need for nutrients and oxygen. It has a high rate of blood flow, uses a great deal of oxygen, and also uses a great deal of glucose, so that increases the risk of toxic danger. The solution then is the blood-brain barrier. So these are capillaries in the brain that do not allow drugs to pass as easily as capillaries in the rest of the body. And the structure of that blood-brain barrier is particularly important as we start to understand any psychoactive drug and its effects. In fact, when we get to cocaine, we're going to talk about how one of the potential treatments for cocaine abuse is a vaccine that will block cocaine from passing through the blood-brain barrier by changing its structure. And so that is a really interesting potential solution to this kind of problem. The final barrier to consider is called the placental barrier. This is, of course, the placenta between mother and fetus. Drugs cross primarily through there by passive diffusion. It is not a good barrier to drugs. The fetus is at least partially exposed to essentially all drugs taken by the mother. And of course, we see this on the news a lot when we see mothers who have abused drugs while they're pregnant. The babies are often born addicted to those drugs. And so we're going to talk about the teratogenic effects of various drugs as we move through the semester. So the placental barrier is not a particularly good barrier for most of the drugs we'll be talking about. The next area of discussion of the distribution of drugs throughout the body is the termination of drug action, or this really is the metabolism of how drugs are eliminated. So there are a variety of ways in which drugs are eliminated from the body. The kidneys are the primary way in which drugs are eliminated, or their metabolites are eliminated. So they're excreted in urine, and of course this is why people do urine testing for drugs of abuse. Lipid-soluble drugs are usually reabsorbed, and so must be transformed into metabolites. So drugs that are fat-soluble have to go through a variety of metabolic processes before they're finally broken down. So they're first passed through the kidney. They don't go out at all, and so they are reabsorbed and have to be transformed into metabolites. The lungs are another route of elimination. This is usually typical for only volatile or gaseous agents. So alcohol, it's the reason why you can detect alcohol in someone's breath, because as alcohol passes through the lungs, it is a volatile chemical, and so it is coming out through people's breath, and of course it's one of the reasons why you can smell alcohol on people's breath. And then of course inhaled anesthetics. Then the other routes of elimination are the intestines. So this is excreted through bile, then can sometimes be reabsorbed through that route. This is one of the primary routes of elimination for marijuana, is through fecal matter. And then finally the skin via sweat. So you can actually sweat some drugs out, and certainly again I think many people have had the experience of either themselves sweating out liquor or being around somebody who is sweating out liquor. Metabolism, or what we also call biotransformation of drugs, is a really important, another really important process to understand in terms of trying to understand how drugs work, how to dose drugs, how to safely administer drugs or take drugs. So by definition, these are chemical changes that usually reduce the effects of drugs and increase their excretion. The kidneys, of course, filter waste from the blood and collect it in the bladder. Lipid-soluble drugs are hard for kidneys to hold on to after collection. Those molecules tend to pass back into circulation before they're excreted. And as a result, they have to be biotransformed. So they have to be turned into something else in order for them to be excreted. And oftentimes, it is whatever the product of that biotransformation is that drug tests are looking for. So for example, a drug test doesn't look for the presence of cocaine in the blood, it looks for its metabolites. And so that's how that process works. So of course the liver detoxifies our blood. So it protects the body from toxic substances and breaks those things down. So it contains enzyme systems that can detoxify any kind of harmful substance. This changes substances from highly lipid-soluble to less lipid-soluble, so they can actually be excreted. They're more likely to ionize and may produce other lipid-soluble molecules, which we might call an active metabolite. And this is, again, another important consideration because many drugs have active metabolites. And as a result, the metabolic processes change dramatically. If there is an active metabolite, the half-life of the drug isn't related to the drug itself, but oftentimes it's active metabolite. There are other instances in which the active metabolite is actually what we're interested in. And so we'll see a couple of instances of that with painkillers. And now we're interested in the effects of ketamine on depression. And it's not ketamine itself, but an active metabolite that seems to have its effect. So this is, again, a critically important process to understand. So how does the liver handle drugs? Well, there are substances that transform drugs are enzymes. These are just simply different kinds of proteins. Most are nonspecific. These are usually part of what we call the cytochrome P450 family. So they're the microsomal enzymes. Again, the cytochrome P450s are the ones that handle pretty much all of the drug metabolism that we're going to talk about. So when we talk about cytochrome P3A4, it's one of this family of the cytochrome P450s. So again, these are physically located in hepatocytes, which are the cells of the liver. Take a quick look at the proportion of drugs metabolized by the major hepatic cytochrome P enzymes. So you can see that cytochrome P3A4 and 5 metabolize most drugs. That cytochrome P3A4 is, of course, inhibited by grapefruit juice and consumption of grapefruit. There are also some drugs that inhibit the production or the functioning of cytochrome P3A. And so that's something that you have to kind of watch out for. And so be very careful about drug interactions. So these cytochrome P450 family of enzymes are responsible for most of our drug metabolism. So there are two major phases of drug metabolism, conveniently named phase 1 and phase 2. Phase 1 is usually a cytochrome P450, again mostly concentrated in the liver. And again, there are about 12 cytochrome P families. 1, 2, and 3 are the most common for drug metabolism. Cytochrome P2D6 and cytochrome P3A, especially 3A4, metabolize over 50% of the drugs that we take. And so these are critically important to understand the metabolic processes for drugs. Factors that influence cytochrome P450 enzyme activity include disease, particularly of the liver. So anyone who might have hepatitis or any other kind of fatty liver disease or loss of liver functioning will have difficulty metabolizing drugs as we get older. Oftentimes we lose the ability to metabolize drugs more efficiently. And keep in mind that if you have used a high portion of your liver recently, it gets tired just like the rest of you. And so oftentimes if you have taxed your liver with, say, a weekend out partying with your friends, drinking a lot of liquor, your liver is going to be taxed. And so any other drugs you might take, so let's say you get home on day 3 and decide to take an Ambien to help you sleep, no, that's going to really probably knock you for a wallop because your cytochrome P450 enzymes are going to be relatively depleted. And so it's going to take a lot longer for you to come back around from that. Of course, your species is going to depend on your activity. We're going to talk about humans mostly. Your age, again, there are pretty significant changes in both the young and the old. Older adults have much slower metabolism, and we have to understand, and we'll talk about this later in the semester, children are not just smaller versions of adults. So you can't just assume a lower dose will be the same in a child, because that's just not how it works. Children have very different drug metabolic processes. Genetics are also very important. This is an area in which we're learning so much about how genetics interact with drugs. Some general basic things to keep in mind is this is an area called pharmacogenetics and pharmacogenomics, and we are now starting to see that you can actually take someone's genetic profile and try to find drugs that will work well for them. But there are other very interesting phenomenon emerging. We've recently it's discovered that people who have red hair, genuinely red hair, are very efficient drug metabolizers, and in fact require about double the level of anesthesia as someone who does not have red hair. So there is a genetic part of that profile that results in a very efficient drug metabolism. We're going to talk more about that, about efficient metabolizers and less efficient metabolizers. And then finally is environment. So what you've eaten, what's going on, are you stressed, are you not stressed, are you healthy, are you exercising, did you just run 20 miles, have you not eaten in 2 days? All of those things are important parts of how your metabolic processes are working. Enzyme induction is a really fascinating part of how we start to develop tolerance for drugs. So past experience with drugs will affect the enzyme systems. They function much like your immune system. When you're exposed to flu, then you won't get that same flu again. So levels of enzyme can actually be increased by previous exposure to a specific drug. And this is called enzyme induction. That is, that experience induces the release of those enzymes. What's interesting about this is a learned process, basically like Pavlovian conditioning or classical conditioning. That is, if you see cues associated with drug use, your body will start producing those enzymes. So if you see, let's say if you were somebody who used cocaine and you see somebody else doing cocaine or cues associated with that, your body will start producing enzymes to start breaking that down more quickly. So to give you some examples and some consequences, St. John's wort stimulates the receptor in the liver to induce cytochrome P3A, which breaks down many other drugs. So things like asthma drugs, warfarin, which is an anti-clotting drug, birth control pills, and the immunosuppressant cyclosporin. So if you're taking St. John's wort, it will actually cause you to break down those drugs more quickly and make them less efficient. And so anytime you induce a cytochrome P3A, you're going to have less breakdown, or you're going to have more efficient breakdown of those drugs, and so less influence out of them. And so St. John's wort can actually make birth control pills no longer work. Enzyme inhibition is the exact opposite. Some drugs will inhibit cytochrome P enzymes and increase their own levels, as well as levels of any other drug metabolized by that enzyme, and this can produce some toxicities. So if a drug is inhibiting a cytochrome P enzyme, it's going to have a dramatic effect on the metabolic properties of other drugs as well. So for example, you can get inhibition of antipsychotic medication by selective serotonin reuptake inhibitors because of enzyme inhibition. Again, in the past decade, studies have shown that grapefruit juice can induce a several-fold increase in levels of particular drugs and can result in augmented therapeutic or toxic effects. So for example, Buspirone, which we talked about earlier, you get a much larger effect out of it when administered along with grapefruit juice. So the magnitude and mechanism of this interaction appears to be the result of a significant inhibition of gut wall cytochrome P450-3A4, isoenzymes, and what's called P-glycoprotein. This fruit-drug interaction is of clinical importance. So grapefruit juice is consumed by a large number of households. Grapefruit is a pretty great way to start your day, but you want to be careful if you are somebody who enjoys grapefruit and are prescribed drugs. You want to make sure you let your pharmacist know or check on interactions online. So this first pass metabolism that we talked about previously is where grapefruit juice has its influence. So that gut wall cytochrome P3A4 is inhibited, and as a result, we end up with much larger doses or with alterations in the functioning of those cytochrome P3A enzymes. Now, as I was mentioning, there are some drug interactions with genes. There are some gene interaction with drug metabolism. About 20 to 30 million people have no cytochrome P2DG enzymes. So they have very slow drug metabolism. They get too high drug levels at ordinary dosage. They're at high risk for accidental overdose. And they'll get no response from certain prodrugs like codeine. Codeine is a prodrug because it has to be metabolized into other other components, so it has to be metabolized first. About 50 to 20 million subjects have cytochrome P2DG duplications, and so they get too rapid drug metabolism and have no drug response at ordinary dosage. And I believe this is where people with red hair have that duplication. Red hair is a recessive trait, and as a result, has to be a match in the gene that codes for red hair, and I believe that gene is right there with the cytochrome P2DG gene as a result. But don't quote me on that because that may be out of line, but it's consistent with the data. So, genetic testing can detect slow, normal, or fast metabolizing for specific drugs. And so there is some move towards genetic testing as a potentially important part of trying to find the best drug for people for treating depression or getting them to quit smoking, or oftentimes also for finding the best cancer drug for them. So this is a huge field, and we're going to talk more about it later on in the semester. So to show you some of the significant effects of genetic testing and why it's significant, so you might have genes that produce a normal amount of enzyme. So an antidepressant will help your depression and cause few side effects. A slow metabolizer could cause an antidepressant to build up quickly, causing intolerable side effects, and so you might want to switch an antidepressant or reduce your dosage. or your genes produce too much enzyme, so it's eliminated too quickly, and so you would have to either increase your dosage or find something that's metabolized from a different enzyme. Sometimes drugs are not metabolized and are excreted intact. So, for example, lithium is a drug we'll talk about with bipolar disorder. Some hallucinogenic and potentially lethal mushrooms. And in fact, the hallucinogenic ingredients are not greatly metabolized and are passed to urine. Some Siberian tribespeople discovered this and recycled the drug by drinking their urine. This is actually also true of methamphetamine. So crystal methamphetamine is excreted intact in urine and oftentimes will be recycled by those who abuse that drug. We'll revisit that when we get to methamphetamine. So excretion is primarily, again, accomplished by the kidneys. The function of the kidneys is to keep the right balance of water and salt in the body. We'll filter everything out of the blood and then selectively reabsorb what is required. pH of the urine can be manipulated to alter excretion of drugs and can be useful for eliminating certain drugs in an overdose. So oftentimes altering pH is an active strategy for trying to eliminate drugs. And so oftentimes you get the administration of carbon and other drugs to try to, or other things to try to alter drug pH. Or sorry, blood pH. So that's excretion. The next really important thing for us to talk about, in fact what we'll talk about for most of the rest of this particular lecture, is what's called plasma elimination half-life, or oftentimes called excretion half-life, etc. So the rate of excretion for most drugs can be described in terms of a half-life. That is, half of the drug is eliminated during that half-life. This is much like radioactive isotopes have a half-life. They decay, half of them decay over a certain amount of time. So drugs have this same kind of metabolism. The time taken for the body to eliminate half of a given blood level of a drug. And so half-life is exactly that. How long it takes to eliminate half of the drug. So for example, we take a drug at a time, 0% has been eliminated, 100% is absorbed, so we might usually start this at what's called peak plasma concentration. So we get peak plasma concentration where 100% of the drug we're ever going to get is there. One half-life later, 50% of that drug is remaining. 2 half-lives later, 25% is remaining because now we've eliminated half of that 50%. So instead of percent, think of this as 100 milligrams. So after one half-life, 50 milligrams remain. After 2 half-lives, 25 milligrams remain. Another half-life, we're cutting that in half again, 12.5. Cut it in half again, 6.2, down to 3.1, down to 1.6. For most drugs, we consider pretty much total elimination to occur at about 5.5 half-lives. So for most drugs, the amount of drug metabolized is proportional to the amount of drug present. So this is what we call a first-order system. So we have a certain enzyme that can break down 50% of the amount of an administered drug in 30 minutes. If 100 units of drug are present, then 50 are metabolized every 30 minutes. If 1,000 units are present, then 500 are metabolized every 30 minutes. So you're going to eliminate half of it in those 30 minutes, and then half of that again. So this is not a linear reduction. This is a curvilinear reduction. The system gets rid of the same proportion of the drug in any given time period. So it's not that we're eliminating a certain amount, it's that we're eliminating a certain percentage, and it's almost always half of the drug. So we always talk in terms of half-life. So this is what that looks like. So we have peak plasma concentration and this reduction by half each time. And so for this particular drug, this is a 4-hour half-life. So every 4 hours, we're going from 32 up here to 16, 4 hours later, 8, 4 hours later, 4, 4 hours later, 2, etc., etc. An important component of the half-life nature of drugs is trying to get a drug to its therapeutic window. And so we want to try to achieve what's called steady state. This is a point of balance at which the rate of drug administration approximates the rate of excretion. So we're bringing it as much as we're sending back out. And so we're getting the drug and keeping it within its therapeutic window. This is really important for any drug, psychotherapeutic, non-psychotherapeutic. If we're talking about antibiotics, antiretrovirals, we want to try to keep drugs within their therapeutic window. So if we look at having one individual dose of a drug, we look here at our graph at time 0, we get peak plasma concentration of the first dose, and then it's going to start to drop off out to about 5.5 half-lives is where it's essentially gone. But then we're going to take it again. So we're starting here at this point, and then we're going to get another increase, and it's going to start to drop off. And then we're going to add another one, and then we're going to add another one, and then eventually we'll get to this steady state where it's fluctuating within a certain range proportional to the dosage interval and half-life. So we look at dosage interval and half-life as a way to get that steady state. And again, steady state is attained at about 5 to 6 half-lives, so about 5.5 half-lives. So for example, if you have a drug that has a half-life of 24 hours, we'll take that because it's convenient, on the 5th or 6th day, somewhere in there is where you're going to achieve steady state. So that's the point at which you'll have a nice steady concentration. So you want to try to get into this therapeutic window. So for medical treatment, it's important that the right amount of drug is maintained in the blood. So this is one of the reasons why they're always on you about your antibiotics and taking them at the right time, because they want to maintain that level in the blood. If the amount is too high, the therapeutic effect will not be any better, and there's always a chance for undesirable side effects. If the amount is too low, we won't have any beneficial effect. So with antibiotics, it gets too low, you get things that adapt, and so then you end up with things that aren't good, that don't respond to antibiotics, and so you really want to watch out for that. So drugs should be given in such a way that the blood concentration stays between a level that is too high and too low, and this is called the therapeutic window. Now, oftentimes, they will kickstart this process for drugs that have either very rapid, well, for certain drugs. So for example, the reason in a Z-Pack you take whatever it is, 2 or 3 on that first day, and the first time you take them, is to kickstart that level up. And so it kicks you into that therapeutic window, and then you can stay in that therapeutic window by taking, 1 twice a day. But they want to kick you up into that therapeutic window immediately to try to get you to that benefit. So that's why you oftentimes load those in that first day of a Z-Pack. So finally, in today's topic, we're going to talk about drug tolerance. So this is a state of progressively decreasing responsiveness to the same dose of a drug. And there are a variety of reasons that this might happen. So there are mechanisms that are involved here that include metabolic tolerance. That is, your body's gotten better at metabolizing out the drug. You get cellular adaptive tolerance. That is, the cells themselves do not respond as much to the presence of a drug. Behavioral conditioning processes, that is, you simply behave differently because you're used to the level of the drug. And then finally, physical dependence can occur, in which taking away a drug will cause what we call abstinence syndrome. And we refer to that as withdrawal. So somebody who's trying to quit cigarettes is going to undergo what's called an abstinence syndrome, where they're going to have physical effects because they no longer have the drug in their system and their body's responding accordingly. So to summarize, understanding pharmacokinetics is really crucial to understanding how drugs work, and any drug, no matter what you're taking. It's important to understand these processes because it allows you to be knowledgeable about pharmacokinetics, and that will provide you with the skills to interpret information about all drugs. So this is important for you as a consumer, but it's also important to understand as future policymakers, because understanding how drugs work and are metabolized and the way in which they're administered, all of these things can help us to try to develop better, more coherent, more accurate drug policy, which is based on science. So next up, we will be talking about pharmacodynamics, which examines how drugs